Well, welcome everybody. Thank you for those who are returning and those who are just joining us for the first time today. Welcome to the 2022 New Hampshire PATH Virtual Conference. My name is Tony. I will be your producer for this session, and I am joined by Sherri Downing from AHP. And Sherri is going to go over outreach, engagement, and case management with us. So with that, I'm going to turn things over to Sherri to get us started. Sherri, the floor is all yours.
Thanks, Tony. Hey, everybody, welcome. I hope you had a good lunch, and I'm delighted you're here. And those of you who were in my last session, I'm delighted you're back. And with this session, as Tony said, we're going to be talking about outreach, engagement, and case management. I love these topics. One of my very favorite things to do is outreach. And I think I am also going to say I recognize that you're doing this. Many of you are doing this work every day. And so I will encourage your comments in the chat and read them as time is available and it seems appropriate. And I'm hoping to get your feedback kind of throughout. And then verbally at the end, I'll invite you to come off mute and speak if you are so inclined. So that's kind of how this session will go. What I hope you'll take away with this from this session today is, there we go. Oops. It better hit my stride. This after lunch thing is hard. So what I hope you'll come away with is the ability to name 3 ways the experiences and perspectives and needs of people experiencing homelessness with serious mental illness or co-occurring disorders influence engagement. So these are all 3 things that are really tough for people to navigate. And so we want you to be able to talk about the ways those diverse experiences will impact your ability to engage. I want you to be able to identify 2 strategies for building rapport with people to encourage access to service. I want you to be able to discuss strategies for staff safety during outreach and engagement, and be able to describe 4 case management strategies. Now, I'm sure that most of you can probably do this already, so I am hoping that you will come away from this session with something you didn't have before. And I know that I will come away from this session with something I didn't have before, because I don't think I ever have taught a session where I didn't learn something. So what I would like to start with is, would you please in the chat share your very best tip for engaging people experiencing homelessness? What is, if you can just share one of your tips, that would be great. Who are you? Where are you coming in from? And what is your best tip for engaging? And I will wait a minute for you to type a little bit and move on if I don't see typing, and go back if I find that you've added something to the chat. So what's your best tip for engaging people experiencing homelessness? Thanks, Sandra. Hello again. Active listening. Yeah, I agree. Very important. Friendly approach. Relaxed body language, super important. I think that nonverbal communication is absolutely critical, particularly with people who are coming from backgrounds of trauma, which most of the people we serve are. And then having something to offer for their immediate needs, that is a great one. And it can be sunscreen or bottles of water or bug spray or any one of a number of things. Always remember to be empathetic and understanding. Yep. Non-judgmental, I would add to that list. Having supplies available like socks and blankets. Yep. Have an open mind and heart. Oh, I love that, Janae. Thank you. I think the open heart is critically important to this work. Respecting their interest in engaging or not engaging. Very, very important. Backing off if someone isn't ready that day. Thank you. I love these tips. So thank you for that. And I'll keep, and oh, my team, Janelli, did I say that right? I hope I did. Says, my team works with the local needle exchange program and are able to connect with people through being able to supply basic needs. Also, humor helps as long as it seems appropriate. Absolutely. So thank you for that. You all have a lot to share with each other and with me, so I appreciate that. I wanted to kind of start out with a little overview of homelessness in New Hampshire. The point in time is not a perfect tool, but in many ways, it's the only tool we've got for taking a real global look at homelessness in a given area and in the country. But in the 2020 point in time count, and the 2020 was the last one that we really have available to us, where people went out and did the outreach style point in time count face to face. And at that point, there were 1,675 people in New Hampshire who were identified as experiencing homelessness. Now, what we know is we're not going to get a good picture at all in rural or particularly frontier areas. We're not going to necessarily get a census. What we're going to get is just a snapshot. But at that's a pretty big snapshot of 1,675 people. And of those, it was 1,023 individuals, 652 people in families with kids, 65 unaccompanied youth, 116 veterans, and 352 people experiencing chronic homelessness. This one interests me a lot because this is a really hard definition to meet, as you know. It means that somebody has to have been homeless for a significant period of time or multiple times over the course of a few years, and it means they have to have a disability. Now, that doesn't necessarily mean a mental health disability, but in the case of PATH, that's absolutely what we're looking for. So 352 people who met the definition of experiencing chronic homelessness is a lot. And I'm just going to ask you, what I'm hearing across the country is that people are seeing a real upsurge in homelessness. They're also seeing an upsurge in homelessness among people who not only have serious mental illness and other disabilities, but really the drug use. I think Janelle said, my team works with the local needle exchange. I think we're seeing fentanyl across the country mixed and adulterated into every other kind of street drug. It's pretty scary stuff. And I think it's exacerbating the issue of homelessness in communities across our country. So I would be interested to know, are you seeing more homelessness? Are you seeing more co-occurring drug abuse? Or is it pretty much business as usual in your communities? So I'll watch for comments in the chat. What I'm hearing across the country, though, is homelessness is growing, and it is growing fast. And I think, the end of the moratorium on evictions that the federal government imposed probably is having some bearing on this, but it's a little scary and pretty interesting stuff. So why do people become homeless? And I would be interested, again, to see if you want to add anything to the chat, but we know that anybody can become homeless. It can happen as a result of extreme poverty. Backgrounds of significant trauma can play into this, and we'll talk a tiny bit more about trauma as we go forward, because trauma is pretty inextricably linked with homelessness. We know that housing has become increasingly difficult to find. Particularly affordable housing is a very much an oversubscribed resource in our communities, and wait lists can be years long, even if there even is a wait list for public or affordable housing. What we know is the housing prices across the country have skyrocketed. People have cashed in. A lot of people are buying up property to use in other ways, like bed and breakfasts or B&Bs. And so it's gotten way harder to find affordable housing. There wasn't much to begin with. And we're seeing people pushing into communities across the country, buying up housing and renovating and upscaling a lot of the housing that was affordable to our populations. I'm going to see what you all are saying. Sandra added, we are seeing an increase in homelessness in Nashua, more complex cases. Yep. We've also seen a big jump in homeless elderly. That's interesting. I would like to hear more about that, Sandra. So maybe at the end you can speak to that a little. What we know is that people become homeless because of a lot of factors. It's chronic health conditions, and it's domestic violence, and it's systemic inequality, and the list goes on. Somebody in my last session said there are as many stories as there are people experiencing homelessness, and no two are the same. So you're going to see people becoming homelessness for a whole range of reasons, and they're going to be becoming homeless for reasons. You could go through a checklist, and it might be, this person has 4 in column A, 6 in column B, 3 in column C. It is a complicated, it's complicated. So people become homeless for all sorts of reasons. That said, oftentimes when you're having a discussion with people who don't work in our field, they'll say, well, they just are using substances, or gosh, they have mental illness, so of course they're homeless. The reality is we all know people who experience mental illness and they are perfectly and well housed. We know people who use substances who are in housing and maintained housing and have for years. So it isn't any one factor that probably is going to tip somebody into homelessness. Although if I had to choose one of these factors for being one of the primary or base reasons that people become homeless, it would absolutely be poverty. When you have to choose between groceries and rent, when you have to choose between rent and gas for the car to get to work, when you have to choose between healthcare and housing, these are tough choices, and they can absolutely start the domino effect of tipping into homelessness. And I know you all know that. What I think too, though, is that it becomes a vicious cycle. So anybody can experience some homelessness. Some of us have been luckier than others. And for years, I mean, I'm 67 now, so I'm older. My parents are gone, but until my parents were out of the picture, there was never a time when I had a doubt that if things really went south, I could have gone home. Many people that we're dealing with in homelessness simply don't have that. But anybody can experience homelessness, and it becomes a vicious cycle. So physical and mental health conditions can be a cause and a result of homelessness. And once you are ill, I've been doing some work lately with medical respite care centers, and it's been a wonderful and affirming project, because what we can see is that people who go into the hospital and come at with any kind of debilitating condition, it doesn't matter. It could be a broken leg or a wound or COPD or heart disease or diabetes. Somebody goes into the hospital, but if they're going into the hospital out of homelessness and they have no place to return to when they're released from the hospital, the obvious result is they're going to get sicker, and they're going to go back pretty soon, and they're going to get a little better and be put back out and get sicker and go back a little sooner next time. And oftentimes people end up dying. What we know is that people who have a place they can go, where they can rest and recuperate and get back on their feet and connect, because homelessness is really isolating. They connect with the folks who are running the medical respite centers. They can begin to connect with services. They can recover IDs. They can begin to get on wait lists for housing and all the rest that you need to have a sustainable life in the community. Physical and mental health conditions, though, exacerbate with homelessness, and they can be a cause and a result. So you're going to get sicker and sicker and sicker the longer that you're on the streets. And mental health also can absolutely be exacerbated. It is hard to hold on to your medicine if you are trying to survive in a condition of homelessness. I just want to talk a tiny bit about trauma and homelessness because it's pretty ubiquitous. What we know is that people who are experiencing homelessness is they're coming from backgrounds often, if not most of the time, of extreme trauma, so adverse childhood experiences. If you haven't read this study, and I have it cited at the bottom of the slide, if you haven't read the adverse childhood experiences study, and I hope you have, but it's one of the things in my long career that has really resonated with me. Adverse childhood experiences are things that happen to a child, and they fall into 3 categories. So it can be abuse, physical, emotional, or sexual. It can be neglect, like physical or emotional, or it can be household dysfunction. And I often think about this as things that happen directly to the person, abuse and neglect, or things that happen in their sphere, in the home. So it could be mental illness in the home that hasn't been treated. It could be substance use in the home that hasn't been treated. It could be interpersonal violence between parents or partners. It could be an absent parent or a loss through death. It's things that happen in the household that are, that are witnessed and that people have to survive. I mentioned this in my last session, so forgive me if you were there, but I will say I just finished reading the most wonderful new book by Barbara Kingsolver called Demon Copperhead. And it was absolutely one of the best studies of childhood trauma and the effects of that that I've ever read. She kind of patterned it on David Copperfield. If you read that, it was a Dickens story. I loved that book. This one was sort of deliberately paralleling that, but it was profound. It was absolutely a profound study of how trauma affects a child and then how it affects the child's outcomes. And so what we know is that if a child has, multiple adverse childhood experiences, they're going to have adverse adult outcomes. It's almost inevitable. And the results of the ACEs study demonstrate an amazingly clear correlation with all kinds of adverse adult outcomes. Now, you would think, well, sure, depression or PTSD or, some of the other mental health disorders. But no, it's heart disease, it's liver disease, it's diabetes and cancer and strokes. Those are all more common in adults with high ACE scores. And high scores often also predict autoimmune diseases in women. And this correlation might be partly due to the effect of chronic stress on developing brains. So the adverse childhood experiences and the stress they cause really don't just stop when the abuse or the neglect or the household dysfunction stops. It continues on, and it continues on in ways that were really, pretty unexpected. You wouldn't think to correlate being abused as a kid with cancer or strokes or heart disease. And yet the data is really clear. This study started with Kaiser Permanente in California, when a doctor just started a conversation with a woman who was hugely, dangerously, morbidly obese. And just in the course of the diagnostic conversation, asked her if she had, a history of childhood sexual abuse, childhood physical abuse, childhood emotional abuse. Well, the interesting thing was she just went all to pieces and admitted that she had absolutely been sexually abused. And he thought, well, that's sad and interesting. But then he started asking other people who were in that sort of morbidly obese bodies. And this turned out to be a pattern. eventually what he decided to do was begin asking people to fill out sort of a forensic description of their childhoods relative to these kinds of adverse childhood experiences, and then went on to study what was happening with them as adults. And it was amazing. It was so interesting, in fact, that the CDC jumped on board and put a lot of resources into studying this. So this is important, and it's really important because one of the adverse adult outcomes we often see is homelessness. So with that, I'm just going to go over here and see what Janae had to say. She says, we will be seeing a lot in Berlin, New Hampshire, because we were on the news this morning, because a lot of landlords that have apartments and houses have not paid their taxes. Well, that's super interesting, Janae. Well, we'll see what happens next. I'll be interested.
Yeah, they're going to be exiting, exiting a lot of people out of their apartments and hotel and homes because of this. 6:30 this morning, I was watching the news, and our mayor came on, first time of me ever seeing him, and discussed this, that we have a lot of apartments, a lot of homes that are being rented out to individuals, and the landlords have not paid taxes in years.
Oh my gosh.
So now the tenants are getting eviction notices, and today I've been getting phone calls and everything, and we're just at a loss right now. It's going to be really bad, and it's the middle of going into Christmas.
Right? And cold. Is
Yes.
it cold there? It's cold here.
Right now it's snowing up here.
Yeah.
Yes,
Right?
ma'am.
Fabulous time to be evicted. Oh my gosh, that's horrible.
Yeah.
Thank you for sharing.
Yes, ma'am.
All right. So I'm going to move into outreach a little bit. I like this term, impactful outreach. It's actually sort of a term of art, and I've got a citation down below, but impactful outreach is an intervention that's very structured, documented, and strategic. But what it really just means is that you meet people where they are. You meet them where they are physically, and you meet them where they are in terms of circumstance. This is another place, and I think motivational interviewing techniques are really helpful here, but this is a place where you can say, who are you and where are you and what do you need? And then listen with your heart, and reflect what they're saying to you. This is a huge gift that you can give to people, to really listen and to listen to them, to learn where they are. And the other thing I really like about this approach is it's respectfully persistent. So just like somebody said earlier in the chat, they may not be ready to talk to you today, or even willing or able to contemplate getting into housing or services. But tomorrow they might be, or the next day. And so being respectfully persistent is critical. There was a woman, I can't remember where she was. I don't remember. It doesn't matter. It was a rather large city. There was this little park where this woman, it wasn't a park in an area where a lot of people experiencing homelessness would hang out, but this woman had been going to this specific park bench for days, and then that turned into weeks, and it turned into months. And an outreach worker noticed her and would stop and chat and take blankets or water, or sometimes little snacks, whatever, over time. And every day she'd say, "How are you doing, Miss May?" And Miss May would say, "I'm doing just fine." And sometimes she'd invite her to sit down, sometimes not, but this was her space. And it took months before Miss May was finally ready and able to begin entertaining the idea of help. But it was only, and eventually they were able to get her housed, and they were able to get her into primary care that diagnosed her issues and gave her and provided prescriptions to medication that she needed. In other words, helped her move on with her life away from that park bench. But it was because this outreach worker was respectfully persistent. It wasn't like, you need to get into housing, you need to get your ID, you need to get into services. And it was really, Miss May, are you ready to talk to me today? And I think that that's a critical skill in outreach. So what is client engagement? And I would love to see anything you want to add to this, but engagement can be defined as the desire and capability to actively choose to participate. The desire and capability, I think I would say capacity in many cases, to actively choose to participate in care in a way that's appropriate to the individual, in cooperation with a provider for the purposes of maximizing outcomes or improving experiences of care. This sentence is awkward and it's a little bit run-on-ish, but it kind of captures all the components of engagement. You need to have the desire and capacity. And it needs to be client-centered services that meet the needs of the client. I often say, if you ask somebody what they need and do your darn best to provide it, then they begin to get better. So, I did a training not so long ago about, we called it saxophone first. We've all heard of housing first and employment first, treatment first, but we called this one saxophone first because it really comes down to making sure that the person who is telling you what they need gets what they need in a way that makes sense to them. And if all they want to do is get a saxophone and learn to play it, so be it. Because one of the things we know about that is, if you meet people where they are and you engage with them in a way that makes sense to them, you try to help in a way that they've told you will help, not only do they begin to get better, but it's a great relationship building strategy, right? So saxophone first. But what you want to do is make sure that you've formed a relationship, and with the intent of maximizing outcomes or improving that person's quality of life. So client engagement, what you do every day. I apologize, this thing is not being cooperative. So here are a few of the engagement strategies that I particularly like. What are some of the engagement strategies that you particularly like? I know that you said bringing goods, being pleasant, a little bit of humor, but personalizing the service, absolutely critical. Not everybody is going to want or need the same things. This is not a cookie cutter job or a cookie cutter program. This is really personalizing to meet people's needs. It means providing access to resources, but as people are ready. So it may be perfectly obvious to you that Miss May needs mental health care and medication for her disorder. If Miss May isn't ready to hear that, you're not going to be able to connect. You need to be able to provide access to resources as people become available to that service or to those resources. We need to be committed to quality care, of course, but the crux of engagement is really being able to form a positive relationship. I love this picture because this gentleman's face is so inquisitive and warm and open. And you think, okay, if somebody who looked like that was coming to help me and saying, so Joe, what do you really need? What can I do for you? I would be inclined to answer him. But that kind of nonverbal communication that he's expressing there, that kind of openness to relationship is really important. And we are dealing with oftentimes people who simply have not had positive relationships before. They may have only had relationships that were abusive or looking to take advantage of, be used for whatever would improve the other person's quality of life. So positive relationships, non-judgmental relationships that are really there for the benefit of the person that you're serving. Huge gift. And one of the most important parts of the outreach and engagement work that we do. So what do we know? I know for a fact that engaging people can take weeks or months or even years. Engagement can be a long process. Outreach, you can outreach over and over and over and over again, but it may be 6 months before Miss May is ready to really even talk to you, much less tell you anything that could possibly put her at risk. Given a background of trauma, people can be really scared of disclosure. People experiencing homelessness often, mostly, maybe almost always, have high needs, and it can be really hard to engage them. We know that. We do this work. But outreach, I love this, and PATH is one of the few programs, the veterans do this a little bit, Healthcare for the Homeless does it a little bit, but it's mostly focused on broader ranges of disability. And in the case of veterans, also, people with veterans experience. But PATH is really the only one who is looking at the most vulnerable people in our communities. Those are the folks who are homeless and who have serious mental illness or serious mental illness and substance abuse disorders, and saying, how can we help you? Hi, I am Sherri. I am here to see what I might be able to help you with. It allows us to bring services to people wherever they are, whether that's on a street corner or up a gulch and gully outside of town, whether it's under a bridge or behind a building or in an abandoned building. We can take services to where people are, and we can begin to be the purveyors of hope. A lot of people experiencing homelessness are really disengaged and distrustful of public systems, and no wonder. They often have, been let down by systems. So it's never, as we know, a great strategy to say, hi, I'm Sherri, I'm from the government, and I am here to help. What we want to say to people is, hi, I'm Sherri, I'm doing outreach for this wonderful PATH program. Can I help you today? What is the thing that you most need today? What would make your life better? And sometimes it might just be some beautiful fruit or a good candy bar, or a bottle of cold water. It can be any one of a number of things. And these are good outreach strategies too, to be able to hand something over, to be able to give a gift, a tangible gift, socks or gloves or warm hats in the winter. My mom was quite interested in this work that we do. And I had gone home to stay with her during her last illness. So she was dying of cancer, sadly. But one of the last things that she was able to do was crochet scarves. And she had made a lot of scarves and put them in the back of her back seat of her car. And she started handing them out to people experiencing homelessness, people who were on the streets and obviously homeless. And there was one gentleman that was standing outside the grocery store, and he'd been there for quite a while. And she'd seen him a few times, and he was kind of a big guy, a lot of tattoos and metal on his, metal, and kind of a scary looking guy, I guess. And she stopped the car one day, and I just watched her. I was fascinated because this wasn't a cause that my mom had ever been particularly interested in. But she reaches in the back and chose a scarf and marched over to the gentleman and reached up, because she wasn't very big, reached clear up and wrapped this scarf around his neck and pulled him into a hug. And my mom gave great hugs. And that gentleman just had tears in his eyes. And he hugged her back, and they stepped away, and she came back to the car, and we went on with our day. I was so proud of her, and I was so tickled. But it was well into the summer, early summer, I guess, late spring, because she left in June. But that gentleman was still around downtown and he was still wearing that scarf. We know that people become disengaged and they become fearful of engaging and being touched. And that means touched emotionally or spiritually or physically. And that was a gift that she was able to give. It was something tangible. And I love that she did that. But I know that that is really just a form of what you all are doing every day. Needs, we all know Maslow's hierarchy, and I kind of like Maslow's hierarchy. But when you are living on the streets, when you are living in a physically, emotionally, spiritually precarious place, all of your energy and being is going to be focused on getting food, getting shelter, getting warm, getting dry, maybe. And if somebody is practicing self-harm behaviors like use of heroin or other opioids, then a lot of their energy and time is going to be focused on just procuring the next hit. It's staying alive. With that level of it, with a level of addiction, we know that people begin to believe, and there's studies that talk about the fact that the brain becomes convinced that that you will not survive without this drug. This is the thing that is keeping you alive and going. So if all you're focused on is is physiological survival, there isn't a lot of time to think about much else. If you can get that stuff sort of nailed down, then you can move on to staying safe. And that crosses a lot of boundaries. It can be emotional or spiritual or physical, but being safe might involve having a door that you can close and lock. It might involve having people who care about you and people who will have your back if you need it. And then that can move up into belongingness and love, and then esteem, and finally self-actualization. But the needs lower down in the hierarchy, have to be satisfied before you can begin to move up. Sorry about that. I'm going to have a sip out of my boxer cup there. So the sense of safety is an interesting thing. What feels safe to me may not feel safe to you. In fact, it may feel dangerous to you. There's lots of types of safety that we need to consider. And it's particularly important to consider these when you're working with people who are experiencing homelessness, because they often have so little control over their environments and their levels of safety that you've got to be exquisitely respectful. People who haven't been welcomed into a business or a restaurant, or people who others will avoid or look down or look away or cross a street to avoid, are at significant risk. You need to think about their physical safety issues. Are they at risk of violence or physical harm? And I will also tell you that something you probably already know, but that people experiencing homelessness, particularly those with serious mental illness or developmental disabilities or substance use disorders or combinations of all, are at higher risk from the people who aren't homeless than they are from other people who are homeless. We are not at risk from those folks. They are at risk from us. People need to have psychological and emotional safety, free from triggers, which can be really tough because you don't always know what people's triggers are. But if you're going to be working with people, as you're working with them through the outreach and engagement process, you really need to think about, how can I be non-judgmental, empathetic, hear with my heart. People need to be culturally and racially safe. They need to have self-efficacy. They need to drive the bus. I'm not sure. I wasn't anywhere near that when it moved. And they need to have a sense of security. So, some people are more risk averse and they'll feel more secure than others. But these are the kinds of things that this particular article talked about in terms of sense of safety. As you're practicing outreach and engagement, these are the kinds of things you need to think about. You need to be welcoming, accessible, approachable, accepting, and responsive, sort of like R. But this is the kind of welcoming behavior that you need to practice on a daily basis. And I love that guy's smile. It's just a really welcoming, open smile that says, come talk to me. I'm a pretty good guy. And here are some of the engagement strategies. And I know that you will be able to add a lot to these, but you need to listen, and you need to listen deeply and well. You really need to hear people's stories. I have never heard the same story twice, and I've spent decades listening to people's stories, many of them experiencing homelessness. No two stories are the same, and typically they're not happy stories, but you need to hear the stories. You need to be consistently present. Don't make promises you can't keep. Don't say, I'll be here at 10 and not show up at 10, show up at 11. You may only have that one chance to connect with somebody who's been let down over and over and over again through their life. You need to follow up and follow through, help people set goals, and know that it's okay to take baby steps. Baby steps are fine, even if it's just walking us to the door of the Social Security office when you need to replace your Social Security card. Maybe next time you'll get up to the, right up to the desk, and maybe the time after that you're going to get in to see somebody. The truth is, it might be baby steps, and that's okay, because every baby step is progress. You need to equalize the client-staff relationships. You need to meet people where they are and let the client drive the bus. It doesn't matter how debilitated somebody is. He or she or they are still the expert in their own life. And then here again, practice exquisite respect. People who have not been treated with respect lately or ever deserve that. You want to avoid re-traumatizing, of course. You don't always know what that means, but if you practice creating safe environments where you want to use a non-confrontational soft approach, you want to keep your arms open, you want to have an open and warm, welcoming expression on your face. You want to remember at all times that people with a history of trauma, and that's basically all the folks we serve, might over-respond to neutral clues and under-respond to danger. This is part of what they've been through and what they've learned. So it may be, I may reach into the drawer for a pen and somebody may flinch. We don't know what has happened that triggered, but you will be more careful next time reaching into the drawer to get a pen, or you'll say, I'm going to reach into the drawer and get a pen now, because you want to be aware of people's triggers and their trauma response. And it's important to avoid re-triggering trauma. The other thing that can be really helpful as part of the engagement process is helping people identify triggers. You want them to be able to self-soothe and ground and participate in therapeutic activities. And what I have a friend who often says this, and I like it. And she says, what I do is I encourage my clients to find one thing they can see and identify it, one thing they can touch, one thing they can smell, one thing they can feel. And she says, by engaging your senses with the world around you, people ground and you can just watch them sort of visibly self-soothe. And she said, that's a really useful strategy. Trauma-informed engagement absolutely acknowledges the person. You leave a lot of this in their court, and you want to say, I'd really like to talk about your homelessness. I'm sorry. Excuse me. I really want to talk about your homelessness. Is that okay? Would that be all right if we do that today? I'd like to talk for maybe 10 minutes, maybe 15, if you've got that long. People are busy. When they're homeless, they're busy. There's a lot to get done during the day. You've got to make sure you get to places that are serving food, maybe where you get treatment, or participate in a self-help group like AA or NA. You might have to get in line in time to get a bed for the night. People have you want to be respectful of their time. So indicate how long the discussion will take. I'm sorry about that. Physical engagement strategies, always approach at an angle, make sure people see you. Identify yourself well in advance if you can. Hi, I'm Sherri. I'm with Path Outreach. I just came to see if there's anything I can do to help you today. Make eye contact, although with some folks, and you'll learn that, I'm sure you guys could talk to me about this. You all could talk to me about making eye contact. Some people are really reluctant to do that. That might be cultural, or it might be because somebody's been in prison, or it could be any number of reasons. There are people who are going to be reluctant to make eye contact. But, in mainstream culture, making eye contact is good. It can also be perceived as threatening. So you've got to be really aware of the reaction that the person you're approaching has to you. You want to keep your hands at your side and not in your pockets or crossed across your chest. Or if somebody's sitting on the ground, crouch down at eye level. What else? What other kinds of physical things do you employ to make sure that you're able to connect with people? I'm going to give it just a second. And I'll look up in a second. Don't block the only exit people may have. Absolutely. Thank you. Yeah, don't block the exit. Make sure that people have a clear way out if you're in a building or an office environment. Or, yes, thank you. So when a person knows that he has been deeply heard, his eyes moisten. I love this. This is Carl Rogers, one of our old favorites. But when a person realizes he's been deeply heard, his eyes moisten. I think there is some real sense that he is weeping for joy. It's as though he were saying, somebody heard me. Somebody knows what it's like to be me. And I love that. And I particularly love that in the context of working with people experiencing homelessness, because they often are not seen. They often are treated as if they were invisible. And that is as painful as a physical blow. We can measure that. You want to go from a strength-based approach. You want to absolutely look to see what somebody is good at. And people who have survived on the streets, even with disabilities, maybe particularly with disabilities, are resilient and resourceful and strong, and they have figured out how to survive. So you want to look for their strengths, and you want to call attention to their strengths. Somebody might be a great leader. Somebody might be a great speaker or have a great sense of humor. They might be able to find a safe place to sleep on the darkest night in the worst weather. Dignity and respect matter, and seeing somebody's abilities matters. Purpose and meaning in life are key motivators. I think that that's true. When people begin to find connection in community and ways to help, I think that that makes a big difference. I have spoken with hundreds and hundreds of people experiencing homelessness over the years, and I have virtually all have been generous with their stories, generous about answering questions or talking to me. People want to help, especially if you say, I'd really appreciate your help. Can you tell me, what could we do to help you better? Tell me your story. People want to have purpose and meaning in life. And if they think they're helping others, that can be a great motivator. Hope absolutely is the foundation for recovery. And when people begin to transcend the trauma and transcend the bottom rungs of the oh, good grief, the matrix, they begin to have hope. They begin to envision a future that, is better than what they're living right now, and success begets success. So these are all we've already talked about a lot of these, but let people identify their needs and priorities. Use motivational interviewing approaches to address the issues, but let the person set his or her their own goals. Support and acknowledge as people move forward. Keep the task simple. Like I said, baby steps are good steps because they begin the journey. And don't judge. Listen without judging. And don't assume people know what to do. And you want to remove barriers to client success. So these are all pretty much about acknowledging success and helping people move forward. You want to absolutely assess the risks. You can't step in front of the risky behaviors. You can't make people stop. You can't change the behaviors. But what you can do is, acknowledge risky behaviors or attitudes or environments and express concern and say, I'm worried about you. That's a really scary neighborhood. And, I know that your ex-drug dealer lives there. So it's in old-fashioned language. It's an occasion of sin. I'm worried about you. But I think expressing concern and offering resources. How about, have you ever tried going to the drop-in center? That's 3 blocks north. Can be a really good strategy to just offer up other resources. So these are some of the questions I like to consider. I would be interested to know which of the questions you would like to use. So what is the risk of death? What does this person most need that you can offer? I think, how is the person feeling? What is the body language like? Is he physically sick or in pain? Can this person engage with me right now? Or where is this person staying? Where is he or she or they sleeping? Who's around them? And is the person safe? And these are all things you need to be aware of in your work as you begin working toward engagement. Establishing connections through resources. I think you guys have this one pretty well nailed. You brought it up right at the beginning. But people experiencing homelessness need a lot of things. And, offering those with a smile can go a long way. I met a gentleman who was down by this was where? This was Mississippi. It was a hot day, and he was just down by a highway overpass. And we stopped and asked to see what he needed. And he said, I would just love a bottle of cold water. And, I was with a path outreach worker at that point, and she had cold water, and we offered it up along with some granola bars and sunscreen, I think, and maybe a neckerchief. But it was wonderful. And he, she'd been working hard to engage him for a little while. And it was, I think, the week after, 2 weeks after, she was finally able to engage him in services. You want to bring care in ways that the person can receive it. So that might be helping solve a problem. So you don't have a safe place to sleep tonight. I could make a few calls and see if I can get you into the shelter. Helping access desired resources, first aid or medical care. Can I take you to the doctor? I see that you're really swollen and inflamed. So you told me last week that you have heart problems. Can I take you to the doctor? Can I take you to the emergency room? Because this is dangerous for you. And use your motivational interviewing skills. How can I help you to, you don't want to ask anything that can be answered with yes or no. Instead, you want to say, how can I help you today? Or what would it take for you to move forward with getting into housing? What would we need to do to make that happen? These are all factors that can enhance motivation and critical, it can be, I can be really ready to get help today, and tomorrow my stress levels may be through the roof, and I won't be ready to hear you at all. Critical life events, negative consequences. These are all things that can enhance or destroy motivation. I love these motivational enhancements. We want to absolutely talk about providing feedback, making sure the individual knows he or she is responsible for change in decisions. Advice on change is clearly and supportively given, but not judgmentally. A menu of options is useful. Empathy and self-efficacy are all critical to this process. Words are important. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And I particularly love that. Discretion is critical. Telling people where people are staying can absolutely put them at risk. I absolutely do not ever tell stories about or tell where somebody is staying unless I'm absolutely sure that it is not going to put my client at risk. Outreach is a long process. I think that's been really clear through this session. Respect is key, and you're honoring the whole person. This is a process that takes time and patience and follow-up and exquisite respect. So you want to be sure to be safe. And these are all things I'm sure that you know. Go in pairs if you're going outside an area where there may not be other people. So if I go into an encampment, I will always go in pairs. Make sure your supervisor knows where you're going. Knowing somebody in the camp who can serve as a guide, who can sort of give you credibility can be really helpful. You want to enter cautiously, and if possible, you want to have an invitation, but always call out, hello, this is Sherri. I'm doing outreach. Can I come in and talk to you? And don't ever interrupt illegal activity, seriously. And these are a few more safety tips. You want to dress for the environment. Wear closed-toed shoes and socks because you never know what you might step on. It could be a needle with Hep C germs on it. You've got to keep your body be safe. Be safe. Be aware of where you put your hands, and don't touch your face until you've washed. I know that unless you've been if you've been in this field for a month, you already know this. Take hand sanitizer, come with supplies to share, but respect the individual's home and clearly identify yourself, a badge or a t-shirt or something that really makes it clear where you're from. Listen and be very aware of your body language. These are all safety tips. And be respectful of, this is just like visiting a friend or a neighbor. You're visiting someone's home. This is their personal space. This is their physical space where they live, and this is their community. And you need to be respectful of that. It's absolutely critical. Know the area. Learn the needs of every community prior to engagement. So you want to learn about this before you ever go out there, especially if it's an encampment. And really, it's helpful to do initial outreach with people who are known to the residents, so you can get a warm handoff. And basically, what is really helpful in many cases is identifying and establishing some sort of rapport with the leader of the camp, there typically is somebody that's generally looked up to by the other residents. And that person can make the outreach efforts really way more valuable. Prepare. This is back to, if you say you're going to do it, be reliable, develop a consistent schedule, and inform people about it. Inform and coordinate with partners. But again, as we just mentioned, be discreet with information about the camp. People experiencing homelessness are at high risk. I've said it over and over, so I apologize, but be exquisitely respectful. And there's my Maslow's hierarchy that I couldn't think of a second ago, but identify needs. And these could be dental care. Often it's dental care or glasses or ID, or food or cold water. Have a short elevator speech. You can say who you are, what you're doing, why, who you're doing it for. This is really important because people want to know what you, why you're there and what you can do. And keep it simple and consistent. And you can always dream big, but start small. So I just want to talk a little bit about case management. What are you really managing? We are really managing care for people. We are really working with people and managing care, not cases. This is one of my biases. I just think case managers, it's a really spectacularly important job, and you're doing very hard work with some of the most vulnerable people in our communities. But you're not managing just paper and files and HMIS and PDX. This is really about linking people to the resources in the community and making sure they get what they need. So these are some of the case management tasks. You serve as a single point of contact for systems. Oftentimes you advocate for the client, assist with meeting needs that cross a range of systems. You need to know the system really well. You need to be able to build trusting relationships responsive to the needs of the client and understand the diverse cultures that they're coming from. These are the components of effective case management: intake, needs assessment, service planning, and then monitoring and evaluation. You're helping somebody climb a really steep cliff. This intake piece is about learning about the client and where you gather information. You're going to gather demographics and build a relationship and identify needs and goals and health conditions, living situation and environments, social and health services. And then you begin to assess, and building on that information collected, you learn more about the person's challenges and goals, identify their strengths and problems and interests. And then you reassess periodically. You reassess over time because people begin to grow and change and their needs change. You continually monitor and evaluate. So you want to assess the impact programs and services have had for the client and evaluate and monitor progress and focus on short and long-term outcomes. And you do that by asking questions and listening deeply and responding, and using the individualized plan as a guide, and always let the client drive the bus. These are all things that you'll be working from. This is the key personalized plan for each client, and it's wraparound client-centered. The client should be deeply involved in creating it. This is the key. The individualized service plan or individualized care plan or individualized treatment plan, whatever you call it, this is the tool that you use to help people move forward in their lives. It provides ongoing narrative about goals and needs and interventions with this specific client and their demographics and their history, medical and otherwise, goals, challenges. But the plan changes as the person's needs change, and the person should absolutely collaborate in writing the plan. What's included? Goals, absolutely. barriers, and we all know the barriers. These are really tough. I would include strengths as well. And then documentation. These case files and individualized plans should be routinely updated. But what is really important for PATH, and I will underline this, to be eligible for PATH, clients have to have a serious mental illness. They can also have a co-occurring substance use disorder. That's a may, not a must. The must is serious mental illness, and that has to be documented in the case file. It can include a diagnosis, the source of the diagnosis, and a description of the behaviors. It also might include quotes of things the client says, descriptions of body language, beliefs, or other indicators of the serious mental illness. And these factors need to be routinely updated. This case file absolutely has to be the hook that you can hang your hat on to demonstrate that this is a client who is indeed eligible for PATH. And I think that brings us to the end of this presentation. So start where you are, use what you have, do what you can. And I know that you're doing that every single day. I absolutely love the outreach and engagement, and thank you to all of you for the comments that you added. Tony, do you have anything you want to add before the end of this session?
I just dropped in the chat our feedback form. If you're staying with us throughout the day, you don't have to fill this out yet. You'll be able to mark all the sessions you attended. And we really do value your feedback. It allows us to improve events going forward. Other than that, if anyone has any questions or has any comments, you want to drop them in the chat, or we have a couple minutes here that we could unmute and just ask them aloud.
Oh, that's great. Thanks, Tony. I was thinking I need to make sure my clock is set with yours.
Yeah, we've got 3 minutes.
We have a note from Jim Doherty to everyone: don't go in people's tents when they're not there. That is absolutely right. It's like walking into somebody's house. Jim, do you have anything you'd like to come off mute and add to that?
Yeah, no, I just wanted to, sort of echo that it's their home, and that, how would I feel if somebody had been in there while I was gone?
Absolutely.
It's a relationship I'm building.
I think that's absolutely the crux of this whole thing. Do you have anything to add about case management or case files or care plans?
Well, I guess, for me, the care plans are like the easy part. It's really getting to the place where I think you kind of mentioned that this is a long process. That when I first meet somebody, I'm not necessarily going to get their name, right? And it does help to build relationships with, like you mentioned, sort of the person who runs the encampment, or even just a guy who's a regular homeless guy in town. Just being known to some people kind of helps build relationships with other people too, because they'll say, oh yeah, he brought me socks, or he brought me water and Gatorade or whatever, and kind of let people know that what you're doing. Right? I think that it's important that they trust us too. I have the problem where I look like a cop, so I have to be careful that they know I'm not going to talk to the police about where they are or what they're doing.
Mm-hmm.
And I'm kind of big too, to your point about, making clients comfortable. I have to sit back when I'm sitting with people, to the point of even slouching some if I feel like, if I'm reading their body language that they're a little, if things are a little tense, I try and just back up as much as I can and try and help them relax, But
absolutely.
That's all I got, I guess.
Oh, that was wonderful. Thank you for helping me fill our last 3 minutes. I think that is really important to think about, that body language. And I didn't mention cops. Sometimes in some communities, police and sheriff's officers are absolutely your allies. and support. And in others, they're clearing camps without notice. So you've got to know your community. And you've got to keep the folks you're serving safe. So